Well, thank you very much, Rosie, and to the NHS Innovations Agency for this opportunity to present this talk. I'm an interventional cardiologist, and I'm sitting here in Blackpool, which has one of the highest cardiovascular morbidity and mortality in the United Kingdom. So I cannot start off a presentation without a slide showing that the global leading killer is ischemic heart disease and stroke. When we talk about preventing ischemic heart disease and stroke, one of the questions is, does reducing LDL cholesterol matter? And we've got ample evidence now from so many statin trials that reducing LDL cholesterol, when they looked at it in the Cholesterol Treatment Trialist Collaborative, they found that for every 1 millimole reduction in LDL cholesterol, there was a reduction in major cardiovascular events by almost a quarter. But let's look at some figures. If we were to go ahead and treat 1,000 patients with a statin for 5 years and get a 1 millimole reduction in LDL, let's look at the number of major cardiovascular events it would prevent. If we're talking at primary prevention, that would prevent 25 major vascular events. So that includes things like an MI, strokes, or needing coronary revascularization. And in secondary prevention, for those patients who've already had a coronary or event or a stroke or peripheral arterial disease, it would prevent almost double the number of major vascular events, almost reaching 50. Now that's with a 1 millimole per liter reduction in LDL. And if we were to use high intensity statins like we do, for example, a lot of the time when we're treating patients for primary prevention or secondary prevention, and if we can reduce the LDL cholesterol by 2 millimoles per liter, then we would prevent twice as many major vascular events. So that's a very impressive risk reduction. Now, I know slides at this time of the evening can be confusing, and we don't want to have too many data heavy slides. So all I would like you to focus on is that there is a central line here. On the left is the green zone. So reducing LDL cholesterol has a beneficial effect in terms of reducing major vascular events. And by that, I mean deaths from coronary disease, heart attacks, strokes, or needing coronary stenting or bypass surgery. And the red zone on the right side means that reducing LDL cholesterol would have a worse outcome. And we can see that consistently, all the results suggest that irrespective of what the pre-treatment LDL cholesterol level is, what the age is, the gender of the patient, whether they were a smoker before, whether they have diabetes or hypertension or not, they all result in a reduction in major vascular events if the LDL cholesterol is reduced. Now, my day job is putting stents in people when they come in with a heart attack. And every time I do put a stent in, I wonder what could we have done to prevent this from happening in the first place. Now, when we look into a coronary artery, we've got technology where we can look at the artery from inside with intravascular ultrasound. So basically putting a little probe with an ultrasound scanner inside the artery. And for those, I mean, there's a wide varying audience. Many of the audience will know what we're talking about here, but the process of atherosclerosis, which results in heart attacks and angina, results from this atherosclerotic plaque, the fatty buildup inside the wall of the artery, designated by this brown area here, if you can see in the middle diagram. And when they looked at intensive lipid lowering with statins and various other non-statin lipid lowering, they found that there was a regression in the plaque size and stabilization of the plaque. And in fact, if we look at the next diagram and focus on the center purple line, so anything below this means that the plaque or fatty buildup has gone down in size, and anything above that means that it's increased in size. And the bottom axis here is showing the LDL cholesterol level. Obviously, this is an American slide, so the figures are slightly different in terms of units. But what we can see is that there are multiple trials in this area which have shown a reduction in plaque volume with intensive treatment with statins and other medications to lower LDL cholesterol. So the conclusion so far is that LDL cholesterol is associated with major vascular events, and reducing this can prevent a significant number of major vascular events. And that statins are effective both in the primary and the secondary prevention setting in terms of reducing major vascular events. So I tried to look for some numbers needed to treat. So that means basically how many people would we have to treat with statins to prevent one death? And these are the numbers I found. So if we were to treat 83 patients in secondary prevention, so these are patients who've already had a heart attack or other cardiovascular disease, then we would need 83 patients to be treated to save one life and 39 to prevent a heart attack. Now, Rosie Hughes from the NHS Innovations Agency very kindly provided me with this slide, and I'm most grateful for the slide. If we can see in Lancashire, 77% of our current patients with CVD are on statins. But if we could increase that to 82%, we would prevent 481 events in 5 years. And look at that, if we were to get to 90% of our patients being on statins, then we would achieve a phenomenal number of cardiovascular events prevented in 5 years. I think this is a very powerful slide, and it's a slide that's very relevant to us in the local area where we live. Having said that, there are, of course, various guidelines that we know. Obviously, I work in secondary care, so I have selected two bits of guidance documents from the ESC 2019 and from the AAC NHSE NICE 2022 guidelines. Now, as far as the NICE guidelines are concerned, for secondary prevention, of course, we always have to advise on addressing modifiable risk factors. But beyond that, the advice is to start on atorvastatin 80 milligrams once daily, and then after 3 months, recheck the cholesterol levels and aim for a 40% reduction in non-HDL cholesterol. But if a non-HDL cholesterol is not available at baseline, then we're aiming for a non-HDL cholesterol of less than 2.5 or an LDL cholesterol of less than 1.8. Now, the ESC guidelines are more sort of with target figures driven. So class 1A evidence is to achieve an LDL cholesterol of less than 1.8. And there's class 2 evidence to go even lower at less than 1.4. And of course, certainly someone with recurrent cardiovascular events, that's what you would be aiming for. Now, the next thing, so I hope so far I have managed to convince the audience that statins are very beneficial. Lowering LDL cholesterol is very important in preventing cardiovascular disease. And that's, of course, all together with lifestyle changes and modifying other risk factors. But there are lots of controversies regarding statins in certain areas that lack clarity. And in fact, when I was doing a YouTube search recently on statins, there were a lot of videos with very negative comments about statins. So I think it's important that we address some of these. So first of all, are all muscle aches after starting statins related to statins? Muscle aches and pains is one of the most prevalent reasons for patients to refuse statins. The problem with this is that this then deprives them of a very important CVD prevention tool and quickly sometimes labels them as being statin intolerant. But as a lot of you will probably know, there's something called a nocebo effect. So this is where a negative expectation about a drug or outcome is there in the patient's mind, and that prevents them from taking the drug or discontinuing the drug. Now, there was the ASCOT trial where they looked at atorvastatin 10 milligrams versus placebo. The interesting thing about this trial was that it had a blinded phase. So this is where the researcher or the patient doesn't know what their patient is taking. Whereas then they had an open labeled or non-blinded phase where both the researcher and the patient knew what the patient was getting. Now, when the trial was blinded, there was no difference in the rate of adverse effects in terms of muscle aches and pains between statins and placebo. But once the trial became non-blinded, there was a significant increase in the number of patients who were reporting muscle aches and pains after statins as compared to placebo, again, suggesting a significant nocebo effect here. And in fact, a team from Imperial College London have done an N of 1 trial. So where in a patient, they would give them atorvastatin 20 milligrams for a month, then a placebo for a month, and then nothing for a month. And the patients could report their symptoms using a scoring system. And of course, the patient wouldn't know what they're getting. And 90% of the symptoms that patients were reporting on statin were also being elicited by placebo, again, suggesting a significant nocebo effect, and something that we have to be very wary of, because otherwise a significant number of patients will get deprived of this very valuable tool to reduce cardiovascular risk. And I think one of the key things is to address patient concerns, patient education, and avoiding spreading misinformation, which sometimes you see in the mainstream media as well, which is, I think, quite irresponsible journalism. Another question sometimes gets asked, do statins cause diabetes? Yes, statins do increase the risk of diabetes, and in meta-analysis, it's been shown that statins can increase the risk of diabetes by 9 to 12%. But what has been shown is that the majority of patients who develop diabetes already have risk factors for diabetes, and statins seem to potentiate or accelerate this process. Having said that, um, the cholesterol treatment trialist collaborative did some analysis on this, and what they figured out is that if we were to treat 10,000 patients with a statin over 5 years, we would have around 50 to 100 new diabetic cases. But that same population, if we were to treat with a statin, again over the same period, and get a 1 to 2 millimole LDL reduction, we will be preventing 150 to 300 major vascular events. So I think the conclusion here that can be safely derived is that the benefit of cardiovascular disease reduction with statin use far outweighs the risk of new onset diabetes. Again, another concern sometimes is treating the elderly with statins, and sometimes this age group of patients are deprived of this medication. But let's have a look at some facts. So I got this very nice slide from Medscape, and we can see that the average age of a first heart attack in men and in women are above 65 years old. And as people get older, the risk of major cardiovascular events increases. So it's very important that we treat this age group. You know, the problem with statin trials is that the vast majority of trials don't include elderly patients. What the CTT collaborative again did is they looked at 28 trials and they found 14,483. So that's only 8% of the trials were consisting of participants who were older than 75 years. Now they found that statin therapy produces a significant reduction in major vascular events irrespective of age. However, there was a less direct evidence for benefit among patients older than 75 years in terms of primary prevention, i.e. they've not already had cardiovascular disease documented. There was a trial called the PROSPER trial, looked at almost 6,000 patients aged 70 to 82, and they had either had a heart attack or stroke before or had risk factors for cardiovascular disease. And they looked at pravastatin versus placebo, followed them up for 3 years. And there was a significant 15% reduction in the risk of heart attacks, strokes, or death combined. So that was the combined endpoint. So there is benefit in this age group, but the evidence is not always straightforward in view of the lack of participants in this age group in most of the trials. Having said that, when we treat the elderly, it's important to remember that there are other factors that as people get older have an impact on their life. So for example, cognitive impairment, frailty, polypharmacy, and they all need to be taken into account and needs to be a shared decision making. And there are 2 trials that we are eagerly waiting for, which is one is a STARI trial, and another is the preventable trial. The good thing about these trials is that they actually enroll patients above 70 and 75, and they've got good follow-up periods. And they're also looking at not only cardiovascular disease, but also new onset of dementia and cognitive impairment. And this is very relevant in this age group. So having said that, the verdict is that evidence from trials indicates that statins work across the age group. The ESC guidelines uses the statement from the PROSPER trial that there is less direct evidence of benefit among patients age 75 plus who have no evidence of previous occlusive vascular disease. But the key goal when treating the elderly is to extend a healthy life and reduce disability lifespan. So if there's a patient who's above 75 who's high risk, then they should be prescribed statins, and age as a factor should be not considered alone to prevent them from this valuable CVD prevention medication. Now, this is also relevant, again, mostly to the elderly population. Do statins cause dementia or mild cognitive impairment? And there was a paper around 2 years ago where they looked at more than 18,000 patients above the age of 65. There was no difference in the incidence of dementia or mild cognitive impairment between statins and no statins. And similarly, as I mentioned, the trial before, a PROSPER trial, they also looked at cognitive function. Again, there was no effect of statins in terms of impairing cognitive function. So I think at this point in time, there is no clear evidence to suggest that statins have a propensity to significantly contribute to adverse cognitive effects, irrespective of what is sometimes mentioned in the media. But of course, if a patient comes to you with cognitive impairment, then that needs to be assessed properly to rule out other potential causes. And as I mentioned earlier, the two trials, STARRY and Preventable, will shed more light on this topic. So another one sometimes, again, mentioned in the press and in social media is that statins cause cancer. Again, the CTT collaborative looked at nearly 80,000 patients in the trials, 5,000 first cancers, no difference in the incidence of cancers between statins and placebo, and no difference in the location of cancer between statins and placebo. So again, we can dismiss this myth. Chronic kidney disease patients, this is a high-risk population. We know that CKD is strongly associated with dyslipidemia, and we know that cardiovascular disease is one of the leading causes of morbidity and mortality in the CKD population. So we need to do everything we can to minimize cardiovascular risk in this population. And statin therapy has been shown to decrease cardiovascular events in patients who are up to the stage of pre-dialysis. But once they're on dialysis, I'm afraid statins don't seem to have any benefit. Now, atorvastatin is the preferred statin for CKD patients. You might ask why. It's because less than 2% of atorvastatin is renally excreted. So that's why it's the preferred drug in CKD patients. So statins, yes, beneficial in CKD, but not if they're already on dialysis. Another one you may be aware of is that statins cause strokes. Well, there is a link between statins and hemorrhagic strokes. Now, we know that the vast majority of strokes are the ischemic strokes, i.e. when there's a reduction in blood supply due to a clot, or thrombus or an embolus that's blocking blood to the brain. But then there's the other type of stroke where there's a bleed in the brain. So those are the hemorrhagic strokes. Now, in nearly almost 20 years ago, there was a trial called the Sparkle trial, where they had almost 5,000 patients, and they looked at atorvastatin 80 milligrams versus placebo. And what they found is that it significantly reduces the risk of ischemic strokes, but does increase the risk of hemorrhagic strokes. And in fact, the cholesterol trialist collaborative meta-analysis also found that it increases the risk of hemorrhagic strokes by about 20%. So what does that mean in practical terms? So again, if we look at 10,000 patients, and if we were to treat them with statin and get a reduction in LDL cholesterol by 1 to 2 mils over 5 years, we'll be getting roughly around 5 to 10 hemorrhagic strokes. But at the same time, we would be saving or preventing a lot more ischemic strokes. So the overall stroke risk rate would be significantly reduced by statin treatment. So statins, the verdict would be increases the incidence of hemorrhagic stroke, but reduces the overall stroke risk. Another one that's sometimes mentioned is that, LDL cholesterol being too low, is that harmful? We don't have evidence so far from multiple trials that very low LDL, so going to about 1 millimole per liter, is harmful. And in fact, only this year, there was a meta-analysis published in EHA Cardiovascular Pharmacotherapy showing that very low LDL cholesterol on intensive lipid lowering treatment is not associated with any adverse events and maintains a persistent reduction of cardiovascular events. Again, there's no evidence that very low LDL cholesterol is harmful. So I hope so far that we have been able to dispel, and I will now call them a lot of myths. Now that I hope you're convinced that statins are very beneficial, the important thing to realize is that they will only be effective if the patients are actually taking them. And so adherence is a very important factor. And the higher the statin adherence, the greater will be the lipid control. And the greater the lipid control, the more cardiovascular disease we shall prevent, both in the primary and the secondary settings. And that will, of course, reduce our future healthcare costs. So it's got a beneficial effect on a very large scale. Now, there was an interesting study done in New Zealand, in which they looked at the statin adherence between the primary and the secondary prevention population. And since Rocco is here, who works in primary care, and I work in secondary care, I thought this would be a nice comparative slide about adherence. And what they found is that secondary prevention group was more likely to be adherent to statins. And I think one of the obvious reasons that we can think of is that these patients have already suffered a major event in their life, and that might be a motivation to continue the statin. But having said that, there are lots of other factors that might be affecting statin adherence, like age, gender, ethnicity, socioeconomics, and of course misinformation in the media that we've alluded to before, like the nocebo effect. And I think for healthcare policymakers and us healthcare professionals who work across primary and secondary care, getting strategies in place to overcome these barriers is key. So having said that, thank you very much for your time, and I will pass over to Rocco Hadland, who will do the next part of the presentation. Thank you very much.